we're really just focusing on the truth that the IMF is committed to every single patient with myeloma. Some patients are further away from access to therapy, some patients are closer to access to therapy, and we want to do everything possible to provide the best outcome in the diagnosis and in the treatment of multiple myeloma. So what drive these disparities? Again, we can look at features that drive disparities of health in general. This includes things that we know affect everyone's health, and systemic racism, the way the healthcare system is designed and implemented, and specifically the social determinants of health. This is really important. Sometimes many of us who don't face some of these challenges don't appreciate it. Often say, how can I talk to a patient and have them appreciate the importance of a treatment if they're hungry, if they haven't had a chance to have a good meal that day, if they live in insecure circumstances, if they're fearing for their lives at home. These are the kinds of things that so often we overlook, but the things that influence our health. But as we drill down to think more about the myeloma-related phenomenon, we have other drivers. One are the biology of the disease and concomitant or comorbid conditions. What I mean by that is that often we have other diseases, sometimes like diabetes, for example, that is the great mimic of multiple myeloma, meaning we have patients who have been diagnosed with myeloma and have historically had diabetes where they didn't realize that the renal insufficiency or the proteinuria or the neuropathy or the anemia wasn't from the diabetes, it was actually from the myeloma. And so sometimes that can cloud the overlapping features of myeloma. And we know that there are individuals and groups at greater risk of diabetes, like the African American and Latino American population. Next, we have the delayed diagnosis. This is maybe most important for all myeloma patients. Almost every myeloma patient can tell you the story of a delayed diagnosis. Occasionally we may pick it up on an insurance test or something, but more often than not, there's a delay in the diagnosis. The average patient sees their primary care provider 3 times with signs and symptoms consistent with myeloma before the diagnosis is made. And so we want to shorten that time, but we know that time is actually even prolonged in African American, Latino American patients. Then there's access to therapy, maybe the biggest of the drivers of the disparity that we see. And the key areas that we talk about, those 4 things that improve survival in myeloma, those triplets or now quadruplet drugs, stem cell transplants, clinical trials, and more recently CAR T. Those 4 T's, as I call them, the T's of access, we have seen reduced access within the African American, Latino American populations, and indeed others like those who are geographically far away from major centers. And then lastly, the teams themselves that are taking care of patients. We need to take some of this burden and responsibility as doctors and nurses and others on the healthcare team, but often we have contributed to that disparity by ourselves not being sensitive to different cultures and ways of thinking and understanding and providing a method and a way that facilitates a health equity for all patients. So when we think about the facts, what are the key facts? And I've listed 7 of them here. I've talked about the longer time to diagnosis, particularly in the African American, Latino American population, that when diagnosed, African Americans and Latin Americans are actually younger at diagnosis. This is important because we get trained in medical school to think about ages of diseases. Very often people don't think about myeloma until the age of 65 or 70, but that's actually considerably younger in those 2 populations. Thirdly, we know those like myself of African descent are twice as likely to develop multiple myeloma. And so that influences the disparity. African Americans, as I've noted already, are less likely to receive those 4 T's, the triplets, transplants, trials, and CAR T-cell therapy. And there are some biological differences. Now, at first you might say, okay, well, if there is a disparity, like we see here in number 6, that a Black man or a Black woman diagnosed today with myeloma is expected to live half as long as the same aged white man or white woman. We know that's entirely unacceptable. But what is driving that disparity? Could it just be that African Americans actually have a more aggressive form of myeloma? Well, in fact, it's the opposite. We know that African American patients are actually less likely to have high-risk myeloma, more likely to have things like translocation 11-14, which is standard risk myeloma. But I'd like to end this slide with something very positive, which is to say, we know through studies like the VA, where at least theoretically, independent of race, ethnicity, other backgrounds, people are treated the same, we see outcomes very similar between the African American and Caucasian populations. In fact, African American patients do as well, if not better, than other patients in the VA system, which tells us that when we give access to therapies, we can see a big improvement. So what has the IMF done in this sphere? Well, one, having this talk I think is important so that we can raise awareness. But we've created a program, the M-Power program, which will play on words, Myeloma Power, M-Power, which was designed to improve the short and long-term outcomes, initially of African Americans and now other populations as we expand our work in health disparities. And it's really built on three hinges, or three important areas, and they all start with the letter E. Number one is engagement of the community. We want to engage the community so that they know the signs and symptoms of myeloma so they can talk to their doctor if they're experiencing. We want them to know the impact of myeloma in their community, to build trust with community. So we've gone to churches, to fraternities, to sororities, to barbershop, you name it. We'll go anywhere to reach people to ensure that they have the right health education, they understand myeloma. Number two is education. We educate the primary care teams. 70% of myeloma patients are diagnosed through their primary care provider. And as I noted before, they're often having multiple visits before that diagnosis is made. We want to educate the primary care providers to know who should they be thinking about when it comes to myeloma. What are the signs and symptoms that should trigger the tests to look for it, and what are those tests? And so we've done multiple programs, short programs, long programs, tip cards, you name it, everything possible to reach the primary care world. And the third E is to enhance the care of those patients who are being treated with multiple myeloma. We want their experience to be seamless, from the teams that take care of them, so that they're culturally sensitive, so that they understand the way in which care should be delivered, that their teams are diverse and reflect the population that they serve, and that they have access, genuine access, to the treatments we know that make a difference. So this Empower movement is both a national movement where we do things throughout the whole country, and we do social media, Facebook Lives, educational programs that we can do across the country, but also we go city by city. We started in Charlotte, and we went to Atlanta, we've been to Baltimore, to New York, to Tampa, to Virginia, to Detroit. We've been to so many cities across the country because each city is different. And in each place we partner with anybody and everybody to help spread the word of the importance of multiple myeloma in this community. We work with medical and non-medical partners. Often in medical partners, a local cancer center, the National Medical Association, the Black Nurse Association, and then our non-medical partners, as I've said, in so many different venues, including those in churches and fraternities, sororities, as I noted. I can think particularly of a program we did in Indiana where we worked with barbershops, where they have every April, they have health outreach to men, Black men throughout the state, because we know that their health has historically been compromised. And they used to give them educational pamphlets about lung cancer and colon cancer and prostate cancer. Never before did they include myeloma, and now they include myeloma because of Empower. So as you can see here, we've worked in different venues and different settings. We always have a program in New York City around Juneteenth, typically in Harlem or in one of the boroughs of New York, where we know that we can have an impact in reaching people and having them understand the disease more fully. And so share with you some pictures here of a program we did in Harlem last year at the famous Abyssinian Church, where we had the opportunity to not actually just talk about myeloma, interestingly. We had a program there where we actually even talked about diet and health and how they're connected, and is blood connected to our diet as well. And so these public-like lectures engage people, give them the opportunity to learn something general about their health, but of course to focus on myeloma and share the stories of patients who have had multiple myeloma. So we've done this, for example, in Richmond, Virginia. We partnered with the wonderful VCU Cancer Center there, and with their Cancer Center Director, Dr. Robert Wynn, who's really a national leader in health equity and cancer, and it was really a privilege to be able to work with them. Of course, we can't go to every community, and so we try to do things in virtual platforms. We've extensively used our Facebook Live to reach people. We provide education to primary care providers in multiple ways, sometimes at their own conferences like the American College of Physicians or the National Medical Association, sometimes in short clips or long clips, trying to find ways to reach as many people as possible so that they can understand myeloma. And then lastly, I want to share with you one of my favorite programs that we have. We know that African Americans comprise about 14% of the population, but only 6% of us as physicians, and actually only 3% of us as oncologists. And not that everybody needs to be treated by someone who looks exactly like them, but we know that when we have the opportunity to include all backgrounds in our medical world and our medical teams, we know it can lead to better outcomes. And one of the things we wanted to do was to train medical students from the time that they're in medical school about multiple myeloma. And so we created this program called the Medical Student Scholars for Health Equity in Myeloma, where every year, and we're in the third year of the program now, we take medical students, many from historical Black colleges and universities, and pair them with myeloma experts. So 12 students, 12 experts, and they do a project together in health disparities. And then we all gather together at the annual meeting of the National Medical Association in the summer, where each of those students can present their posters. It's been remarkable, the posters that they've had. These are led to publications. This has led to abstracts at ASH, the American Society of Hematology, where many of them have even won abstract achievement awards. All of this is nested at the empower.myeloma.org website that you can look at with the other 500,000 people that have visited this site, where we try to provide resources that wherever someone is, they can find these resources and benefit from them. We've used the full and strong arm of the IMF in social media to try and reach others, to share the stories of myeloma, have people understand it. We are looking in the very near future to have patients from historically underrepresented communities who have been on a clinical trial to share their story with others. Because it's one thing to hear from Dr. Joe, it's another thing to hear it from the patients. And furthermore, as we look to the future, we want to reach out to the whole of the medical community. We've published so many papers in this realm, and we know that that's how we can reach others, teaching them the best practices of health equity in multiple myeloma. As we look ahead to the future, many more cities we're going to go back to, and new cities we're going to go to. We're further expanding Empower to include the Latino American population, starting in South Florida, where there's a known and significant disparity within healthcare in that area, and in particular within multiple myeloma. And we're going to be partnering with our friends at the University of Miami to do so. So as I come to a close, you might ask the question, well, Dr. Joe, what can I do? Well, here's what you can do. Hopefully, you can be greater aware of this huge problem. That disparity is massive, as I've shared. In fact, myeloma is the most disparate cancer within the African American community. But you can do something about it as well. Join the Empower movement, as it were. Learn more of what we're doing. Do what you can in your area to